Hello everybody. Today we are going to talk about pharmacology during coronary revascularization. I know it's a boring topic, but I will try to make it as interesting as possible. And if you can just bear with me for the next, let's say 10 or 13 minutes, I'll walk you through some of the basic concepts about anticoagulation during revascularization, ACS, and STEMI, and it is very important clinically as well as for the boards because there will be a lot of questions about pharmacology. And if you, as I said, if you go through this lecture, at least you'll probably be able to get about 80% of those hopefully correct, because this is going to be a very high yield talk. So with that, we're going to jump on to some of the basics things during ACS and the pharmacology behind that. The way I describe to my patients about the ACS or NSTEMI or a STEMI is that a plaque rupture. So when there is a plaque rupture, it's just like a small volcano erupting everything into the lumen of the artery. So you have platelet activation, coagulation factors, you have macrophages, foam cells, you have that media of the inner layer of the artery exposed to all kind of um, procoagulant factors. So it's a very, very hot spot. So with that, there is a lot of inflammation as well. So unless you do some kind of pharmacological intervention to kind of suppress that process, doing only revascularization with a thrombectomy or a PCI might not be of great benefit. So with that, pharmacology or anticoagulation is as important, if not less, than the intervention that we do during coronary intervention. So I'm just going to broadly divide it into two things. One is anticoagulants or anticoagulation. So you have to inhibit the coagulation cascade, and then the next is the antiplatelets. As I said, it's a very hot spot inside the artery, so there's a lot of inflammation as well, activation of cytokines, prostaglandins, inflammatory markers. So there were a lot of trials done to look at this inflammation and whether suppressing this will be of any benefit or not. Unfortunately, all the data, all the trials so far have been negative. So although we know there is a lot of inflammation at the site of the plaque rupture, giving any anti-inflammatory is of no benefit. In fact, it might do more harm. So no steroids, no NSAIDs, no high dose anti-inflammatory, no NSAIDs other than we know about the aspirin. So with that, we'll move on to the anticoagulants. I'm just going to circle this. The one we commonly use is unfractionated heparin, just because it is fast acting. We can measure the therapeutic effect of it, and once stopped, it quickly wears off within 30 minutes. In the cath lab, the way we determine if the patient is properly anticoagulated or not with heparin is called ACT, activated clotting time, and we usually keep it around 300. And if the patient's ACT is low, then we give another dose or bolus of heparin. So it is very important, as I said, it's as important as doing a mechanical intervention that you keep the anticoagulation up to the mark. Otherwise, there could be high mortality and morbidity during any kind of intervention on ACS patients. Then we have low molecular weight heparin. We don't use it here. It's mainly used in Europe. Basically, what they do is in the ER, the patient gets a subcutaneous injection of a low molecular weight heparin and then sent to the cath lab, and they do the intervention without any other um, anticoagulant. So in patients who have any allergies to the heparin products, or what we call like a HIT, heparin-induced thrombocytopenia, bivalirudin is another one, which is a direct thrombin inhibitor. So that you can use. About 4 or 5 years ago, we were using it quite a lot, just because of the ease of use. Um, it is comes in a bolus. You give a bolus, and then you can, pretty much do the intervention without worrying about monitoring the ACT. But the recent data has shown that the bivalirudin has slightly higher stent thrombosis rate. So that kind of discouraged the use of bivalirudin, but we still use it in patients who have heparin-induced thrombocytopenia. And the other drawback is it is very costly. So for these two reasons, we don't routinely use that. So with that, we come to the second arm, which is the antiplatelets. And as you all know, if I have to put the antiplatelets, it can be put into two broad categories. One is IV, another one is PO. The IV are the GP2BA3 inhibitors, the tirofiban, aptifibetide, and abciximab. The way I remember that from my med school is a mnemonic called T, tirofiban, aptifibetide, and abciximab. And last but not the least, the newer platelet inhibitor, which is an IV form of P2Y12 inhibitor called cangrelor. When do we use these GP2B3A inhibitors or P2Y12 inhibitors? Usually if there is inadequate loading of PO drug. So if the patient is not able to absorb or is not able to swallow the pills, the Plavix, the prasugrel, then you can give. And the GP2B3A inhibitors can also be given if there is a large thrombus burden. But for the most part, we try to avoid these because there is increased risk of bleeding in these patients if you have these GP2B3 inhibitors along with the anticoagulants and the antiplatelets, but we do use it in selected patients. With this, we come to the PO antiplatelets. We know about aspirin, usually give 81 milligram as a maintenance dose and a 325 milligram as a loading dose. And then you have three P2Y12 inhibitors that we routinely use, mainly Plavix, prasugrel, and the ticagrelor. And again, aspirin plus P2Y12 inhibitors, that is your DAPT treatment, dual antiplatelet. And that is something very, very important if you are doing a PCI on a patient, as well as a patient who is NSTEMI and you are just medically treating these patients. You have to have them on tap for at least a year. There are some exceptions, but for the most part, as I said, 1 year is the standard in ACS. When we talk about 3 months, 6 months, those are for the patients who have a stable ischemic heart disease, which is an entirely different category. With that, we just come back to individual drug and some of the basic pharmacological features as well as high yield facts that you need to know about these drugs, which you will be coming across in your clinical practice as well as during the board exam as well. So we start with the aptifibetide, which is your integralin. The brand name is integralin. We use that here in our cath lab, and it is in the formulary. There are two things that you need to know about the anticoagulation. Of course, we know that it causes increased bleeding, but the other thing is it causes thrombocytopenia, so decreased platelets. So you have to monitor these patients' platelet count every day if you have kept a patient on the anticoagulant. And if their platelets go down, you have to stop them, the anticoagulant. Another thing is the renal dosing is renally excreted, so you have to decrease the dose if the patient's got AKI or chronic kidney disease. We have protocols where the usual dose is like a loading bolus, 2 loading bolus, and then maintenance dose of 2 milligram per kilogram body weight. And if the patient has got low GFR or they have chronic kidney disease or acute kidney injury, we lower it down to 1 milligram per kilogram body weight. But these are two most important things that you need to know. One is thrombocytopenia, another one is the renal dosing. Another thing is the aptafibitide or anticoagulant is not reversed. And why is that? Because the drug has a large quantity of it circulating in the plasma. Some of it binds to the platelets, as I showed in these arrows here. On the platelets, they bind the platelets and they inhibit the platelets, but there is a large amount of drug that is free and floating free in the plasma. So if you give platelets, newer platelets, basically what will happen is the drug that is already circulating will just bind to these platelets and inhibit them. So if these patients bleed, then you are in trouble. Of course, you need to give them platelets, you need to give them FFPs, you need to give them the blood products. But for the most part, as I said, giving them platelets will not completely reverse the bleeding, because the drug is so loosely bound to the platelets and circulating free in the plasma. So that is one important thing to remember. Then with that, we come to another drug called abciximab. We don't usually routinely use in our lab. The brand name is Riopro. Unlike the anticoagulant or the aptafibitide, this medication is kind of like a monoclonal antibody kind of a medication, and it binds very firmly with the platelets. So there is a lot of binding of this drug and very few amount in the plasma. So with that, if you give these patients platelets, and if these patients are bleeding, giving them platelets will potentially reverse the effect of the abciximab. So it is reversible. And the reason for that is it's just like a monoclonal antibody kind of a drug which binds very efficiently and tightly with the platelets. And this is something that comes into the clinical practice and something to know about, that you might be tested upon, as well as will be very beneficial in your clinical practice. Somebody is on Riopro, and if they are bleeding, giving them platelet will potentially reverse the effect of the drug. Then we come to the P2 white valve inhibitors. We start with the Plavix. That's been there for a long time. P is for Plavix, P is for prodrug. So it is a prodrug and it needs 2 steps metabolism to get activated. One of that step happens in the liver, and the P450 cytochrome P450 system, and specifically CYP2C19 is the one that causes this drug to be activated so that it can inhibit the platelets. Any mutation in the CYP2C19 will cause these patients to be Plavix resistant. One thing here important to know is the prevalence is very, very low. So very, very few patients have this CYP2C19 mutation. So ACC/AHA does not routinely recommend testing everybody for CYP2C19 just because of the cost effectiveness, as well as since the prevalence is so low. But yes, if the patient comes in, they're doing all the things right, you had very good results with the PCI, they're taking their Plavix, and they just come in with a stent thrombosis and you are concerned about Plavix resistance, you can switch these patients to either of other two P2Y12 inhibitors, and you can send their blood test for CYP2C19. So for the Plavix, things you have to remember, it's a prodrug, needs two-step metabolism to get activated, and the cytochrome P450 system that you need to remember is the CYP2C19 and the mutation to which can lead to Plavix resistance. The Plavix usually takes about 2 hours to inhibit 50% of the platelets. So in ACS patients and STEMI patients, we try to give drugs that are very effective and quickly inhibit the platelets. Since Plavix takes a little longer time, we do use it for stable ischemic heart disease. Imagine a patient who's coming in after a positive stress test. They have a stenosis, but they don't have a plaque rupture. So there's not a lot of inflammation there, not much activation of the clotting factors and all that. So yes, in these patients, you can put a stent and then you can load them with Plavix. But if you are in a situation where the patient is coming with the ACS or an STEMI, you really want to have a drug that will inhibit the platelet activity at least by 50% very quickly. And for that, we have the prasugrel and the ticagrelor. The prasugrel, again, P for prasugrel, P is a prodrug. The prasugrel is also a prodrug, but it does not require any metabolism to get activated. So unlike Plavix, it does not require, fast pass metabolism or something like that to get activated. Things to remember about this drug. This drug is contraindicated in patients who have a TIA, previous TIA or stroke, because they have high risk of bleeding. The other two things that might also deviate you from using this or inhibit you from using this is a low BMI and increased age. So if there are patients who are elderly and their body weight is very low, the guidelines recommend using either the Plavix or the ticagrelor. The reason for that is there is not whole lot benefit. It's not that it is contraindicated, it's just that there is not a whole lot benefit if the patients are elderly and if they have a low BMI. One thing that does favor the prasugrel is the diabetic patients. So patients who have diabetes, for some reason, they say that they respond better to the prasugrel. So if you have somebody who is young, did not have a stroke, no low BMI, they're not elderly and they are diabetic, prasugrel can be a good choice. And the other thing is it's once a day drug as compared to the ticagrelor, which is twice a day. With that, we come to the last drug that we routinely use, which is ticagrelor, which is Brilinta. So unlike Plavix and prasugrel, so ticagrelor is an active drug. It's not a prodrug, it's an active drug. It's twice a day. The only contraindication is if somebody had intracranial hemorrhage in the past. So if the patient had an intracranial hemorrhage in the past, that will also constitute a stroke. So these patients, the only thing they will be left with will be the Plavix. So although you will not see that contraindication of ticagrelor in certain books, but this is one of the things that you have to remember. If somebody had intracranial hemorrhage, you try to avoid ticagrelor. And then the other thing is ticagrelor plus aspirin 325 milligram is not a good combination. So if you are giving a patient a ticagrelor, they should be on aspirin 81 milligram maintenance dose. And there is an interesting story behind that, is because when they were doing this trial, they saw that the data that was coming from Europe and other countries, there wasn't any difference between Plavix and Brilinta, but in the United States, they were seeing more bleeding. And then when they looked into that further, they found out in US, for most of the center were still using aspirin 325 milligram. Europe had gone away using 325 of aspirin a long time ago, so they use 75 milligram of aspirin. and it's been there for a long time. So when they were using Brilinta with 75, there wasn't much bleeding, but in US, since they were using 325, combining with Brilinta caused more bleeding, and that kind of led to the guidelines that if you are using ticagrelor, use 81 milligram of aspirin. And last thing, both ticagrelor and prasugrel have a favorable outcome as compared to Plavix is because within a half an hour they inhibit the platelets by 50%. They inhibit the platelet activity by 50%, and that's what basically you need when you are doing an intervention or a PCI. Thank you very much and have a very good day.